Hello, my name is Taylor Chisdale, and I am a PGY1 at the Baylor All Saints Medical Center Internal Medicine Residency Program in Fort Worth, Texas. This case was a 73-year-old male with a past medical history of diabetes and hypertension who was admitted to an outside hospital for pancytopenia after presenting with fever, sore throat, and dysphagia. The patient denied any history of alcohol abuse or exposure to hepatotoxic chemicals. Lab findings included transaminitis, elevated total bilirubin, elevated triglycerides, and low fibrinogen. Serologic workup was negative for hepatitis, Epstein-Barr virus, IgM, cytomegalovirus, HIV, RPR, Coxiella, and parvovirus. Bone marrow biopsy was done out of concern for macrophage activation syndrome. However, results were found to be normal. Imaging and cultures were negative for any infectious etiology. Initially, antifungals and antibiotics were started for suspected disseminated tuberculosis, cocci, or histoplasmosis. Ferritin was extremely high at 25,000, and since adult onset Still's disease was a concern, the patient was started on steroids and anakinra. The patient was then transferred to a different facility for higher level of care. At the accepting facility, the patient was found to be febrile, jaundiced, with sore throat and lower extremity edema. The patient was admitted with liver failure, renal failure, interstitial pneumonia, pancytopenia, and metabolic acidosis. Steroids and broad-spectrum antibiotics were resumed. Ultrasound of the abdomen showed borderline splenomegaly. Repeat ferritin was now at 57,928. Haptoglobin was low with an elevated LDH, but with a normal reticulocyte count inconsistent with hemolysis. Platelets were low at 4,000, prompting repeat bone marrow biopsy. Results were now consistent with hemophagocytic lymphohistiocytosis, now showing malignant natural killer cells infected with Epstein-Barr virus with florid hemophagocytosis. EBV viral load was 1,100,000. Suspicion was now for HLH precipitated by EBV infection with natural killer and T-cell neoplasm. Pulse dose steroids were initiated, followed by etoposide and rituximab. Despite improvement in HLH pathology, decision was made not to pursue further chemotherapy due to risks of treatment versus benefits for the patient. Patient and family ultimately made the decision to pursue home hospice care, where a patient unfortunately passed away. HLH is a rare yet life-threatening hyperinflammatory syndrome consisting of cytokine storm facilitated by the overproliferation of activated lymphocytes and macrophages. HLH is more common in children but can occur at any age. Disease progression is severe, typically with widespread organ failure, cytopenias, liver dysfunction, and neurological symptoms. Patients may remain acutely ill in the hospital for an extended period before a diagnosis is made. Diagnostic criteria for HLH, of which 5 out of 8 must be present, are fever, splenomegaly, bicytopenia, increased triglycerides or decreased fibrinogen, hemophagocytosis on pathology, decreased natural killer cell activity, elevated ferritin, and elevated soluble IL-2 receptor. This case was notable for an early normal bone marrow aspirate, which is frequently negative for hemophagocytosis in HLH workup. Also notable was an early negative EBV serology, which is the most commonly associated infectious trigger in HLH cases. This case ultimately demonstrates the challenges of HLH diagnosis and treatment, which is often complicated by an elaborate multidisciplinary, sometimes multi-facility workup coupled with a complex and devastating disease pathology.